like if we have international, I'm present in English, okay? So I'd like to present a very hot topic, artificial intelligence in structural heart therapies, especially TAVI. And no disclosure, so we have a case of 85-year-old female with severe bicuspid aortic stenosis. And actually, she had a previous transfemoral TAVR attempt at a different hospital that resulted in a right iliac dissection during advancement of the Evolut effects delivery system. So the procedure was aborted after the balloon valvuloplasty, and they placed 2 stents in the right iliac artery. So this balloon valvuloplasty lasted for about a year for her, so she came back to us for a second opinion. So it's a very, very severe aortic stenosis. This is from the gated CTA. You can see it's a calcified valve. It looks more like type 1 Sievers with a calcified raphe there, and a very asymmetric non-coronary sinus and larger compared to the fused left and right coronary sinuses. So CT planning is obviously the cornerstone, the key for success. So this is the conventional, what I call the conventional annular measurement at the level of the hinge points of the leaflets. But for bicuspid valves, especially when there is asymmetry, I measure a little differently. So I align the crosshairs more like with a natural orientation of the prosthetic valve, having the red line perpendicular to the annulus and the blue line more like how the valve is going to sit there. And you can see that, I take this measurement as well, which correlates very well with the other measurement, because this is where I'm planning to really implant the valve when I do this TAVI. Obviously, we use the embedded geometry. We simulate a 23 millimeter S3 valve there, and this is, again, the height of deployment based on the non-coronary sinus. You see that the valve is actually a little higher than the hinge point of the leaflet. But when we look at the left main, this height of deployment looks good. So vascular access, you can see here the previous stents on the CTA in the right iliac artery, the overlap here. The diameter there was small, so we decided to go to the left iliofemoral system, which had it was still small, about 5.3 to 5.5, the minimum diameter. But I was confident that with a 14 French E sheath, it would be okay because there's no circumferential calcium. So we all know the challenges of TAVI in bicuspid aortic valve. We already talked about it. I'm not going to expand more on that, but we need to be very careful. Recently we started collaborating with Dardas Simulations. It's an AI simulation software. I think there's a similar one in Europe from Netherlands. This software uses the CT scan to create all these volumes, and then to create the models. Based on those models, we deploy different kinds of valves and sizes and implantation depths to assess all this, the sizing, the risk for obstruction, annular injury, pacemaker risk, and even valve thrombosis. So this is now the 23 millimeter S3 conventional deployment. You can see the fused left and right leaflets with green. You can see the calcified raphe here. And this is what it looks like when you rotate. That's a conventional, more like 80-20 or 90-10 deployment. And now this is the high deployment that I was planning to do, because otherwise the valve would be very low and we would risk conduction issues and paravalvular leak. We also simulated the 26 millimeter Evolut FX, which is not my valve of choice for bicuspid aortic stenosis unless there is a contraindication for a balloon expandable. And again, you see the rotation. So So this is now the left coronary obstruction. You can clearly see that there is enough distance from the left coronary because also the valve is getting pushed from the calcified raphe a little bit towards the other side. And you can see here there's adequate distance as well. And this is an index actually we calculate based on the diameter of the ostium and the distance. And if this ratio is less than 0.7, then there is high likelihood for coronary obstruction. And this is the right coronary artery, definitely a little closer, but still safe. And you can see here the opening. There should be enough space to for good blood flow. And same with the self-expanding. So coronary obstruction is not really a big concern here. Now, more importantly, the PVL, because bicuspid valves tend to have more PVL after TAVR. You can see here we simulated 23 millimeter S3. The aortic view and ventricular view, the point here is that we're trying to see if we see any gaps that go through all the way, and we're visualized both from the aortic and ventricular view, and there's no gap in this simulation. So this is now the self-expanding valve, the Evolute, and you can see right here, there's this gap that is visualized mainly because of the eccentricity and the way the commissures of the bicuspid valve are, and we measure a gap of 1.8 millimeters, which increases the risk of more than mild PVL and will require post-dilatation, and we would like to avoid that. But this is what it looks like. So this model gives us also an annular stretch, the degree of annular stretch. And you can see here there is one spot that right here, that from this like calcium nodule from the leaflet, when it kind of getting pushed to the sinus, that the maximum was 1.4 of stretch, and this was published in 2023 last year. Shows that the cutoff 1.6 or higher increases is associated with increased risk for annular rupture based on the model, and we're 1.4, so we're okay. So this is now the actual valve deployment. So deployment is happening at ariocaudal cusp overlap view, so we have complete control over the depth of the deployment. And you will see we have a straight flush catheter in the non-coronary sinus, and you can see how the valve is ending up higher than the non-coronary sinus. I'll play one more time. So that was nominal 23. And this is the final aortogram, ariocaudal view on the one side. You can see how the valve is obviously higher than the hinge point of the non-coronary leaflet, but on the other side, it's just 1 or 2 millimeters below. And this is the LAO view. There's normal flow in the coronaries. We always do the TAV in biplane, so to understand a little bit better 3D geometry there. There's no paravalvular leak. And this is now based on the model I showed you earlier when we kind of simulated the higher implantation, which correlates pretty well. And this is the LAO view. There's good flow in the RCA, good flow in the left main, no compromise. And these were also the measurements of the membranous septum. We had enough membranous septum length, especially with the high deployment. The valve is not even touching the area. And so we have collected a few cases now, and we're planning to present at the TCT conference. Just give you a little teaser here. So that's very, very briefly, 81-year-old, severe AS. You can see this scary CT scan with a small annulus, low coronary heights, and severely calcified and bulky leaflets. So we simulated, again, the main concern here was, obviously coronary obstruction. The left appears to be okay, and here as well, there's enough space. But the right, which was a dominant RCA, is definitely at risk for obstruction. As you can see, obviously, I don't think we need this model to predict that this is a high-risk case, but it's nice to see it also on the 3D model. It gives us a 3D perspective, a different perspective as well. And we simulated also the self-expanding valve, same for the RCA. So the patient underwent actually mini AVR through right thoracotomy, and this was the valve that was visualized intraoperatively with a severe calcification and thickening of the leaflets. So AI, we were saying that it's the future, but I think it's the present. It's expanding very rapidly. And I'm sure that the applications of the AI will increase in the structural heart space, and we should be ready for it. This technology, the DASA simulations, is actually reimbursed now in the United States. By Medicare, it's $980 per case, which is fully reimbursed. And I would like to thank you very much for your attention, and I'll be happy.
Congratulations. It's definitely a very impressive technology. I wanted to ask, how reliable is this technology in relation to the paravalvular leak? In other words, does it take into account the compliance of the tissue? Because it gives you an image where you may see spots that are not opposed, let's say, to the tissue. How does it calculate or take into account these compliances?
Exactly, yeah, that's a great question. So the same way it calculates the compliance of the annular calcifications and gives you the risk, the stretch and risk for rupture, the same way it calculates the compliance of the annulus when the prosthetic valve is deployed. And based also on the shape of the annulus and the ellipticity of the annulus, it gives you this prediction. I mean, it's been validated with many cases that the patient had the TAVR, then they went back and they did the analysis depending on the PVL, and that's how they validated.
Nico, this was very interesting, and I don't know, maybe the solution in this subset of patients that we know that maybe TAVI is not in its best in bicuspid patients. So maybe to have this solution would enhance the better procedure. So Theo, you want something to say? Let me ask you something first, Theo. So would you ever place if you didn't have this information, would you ever place the Edwards that high from the non-coronary?
Same question to you, because the shape of the bicuspid valve is very important. In this case, you made a very high implantation and also in the right cusp overlap weave. Mm-hmm. So this is a chance that the high implantation was done because of the high amount of calcification, because of the supraannular calcification. So it's very important to identify, maybe you can do this with your artificial intelligence program. The shape of the bicuspid is maybe tube flared or, the other.
This was more like a tube. It didn't have a big difference like flaring or
tapered one. If it is, for example, flared one, the intercommuscular distance is smaller than the annulus, then you select the valve according to that measurement. This was a chance that a balloon expandable valve was implanted, very high implantation. Especially in right, for example, in generally we implant the balloon expandable valves, in the tricusp coplanar weave. Yes. So you must be really very careful by using this program, especially maybe it was a chance for this bicuspid anatomy, but normal anatomy, I don't think that it will work properly.
That was specific for bicuspid, and in general, where I trained and how we approached the bicuspid valves, if there was like this big asymmetric non-coronary sinus and the valve was very calcified, we would always try to implant high in the cusp overlap view. That was sort of like the approach. This model, obviously, we don't follow it religiously right now, but that's what we've done in several cases with this type of bicuspid valves, not for tricuspid valves.
But maybe, according to Yannis' question, maybe this model can be developed according to the follow of the right cusp rule. You know, sometimes it's not very easy to find. Even CT gives the right information about the correct angle of the tricuspid coplanar weave, and then we give great amount of contrast sometimes to find the appropriate angle. Maybe this program will help you. But in the first case, I was really very afraid that it was a very high implantation. So I won't put the balloon expandable valve at that position.
So you would prefer to have a self-expanding valve in this case, though?
Maybe I will prefer a self-expandable valve.
Yeah. Okay. So, Petro, do you have something to add?
No, it's. I think this is the future. I agree that it was a bit high, but it depends if it's flared or if it's tapered. The position of the valve. But it was really fantastic. Congratulations.
Anyway, this is exciting technology. Thank you so much, Nico. Thank you for sharing with us. So.